So welcome everyone to this Fujita Alumni Association webinar. Today we have two great speakers, and I will introduce the first speaker very soon. I want first of all to welcome all of you, and I want to thank my co-moderator, Professor Ishu, who always helps me during these webinars. Thank you, Raja and Liu, for the organization of these meetings, and thank you for all the members who joined today. Thank you, of course, to Professor Yoko Kato. She is not connected yet, but I always want to thank her because she always supports us. She supports young neurosurgeons, and she supports these kind of meetings. So today we have the pleasure to have Professor Masaru Hiroata here with us. Professor Hiroata is a full professor at the Department of Neurosurgery at Kurume University Hospital. He is a member of several societies. He is an expert in endovascular procedures, and actually today he's going to talk about endovascular treatment for cerebral aneurysm from the beginning to the present. So welcome, Professor Hiroata, and thank you for joining us. Please, if you want to share your screen and start your talk, it will be a pleasure for us to listen.
Yes, thank you very much for introducing me. Thank you very much for introducing me. So I'm Hirohata. I'm living in the southern part of Japan. Maybe all of you visited the Fujita University, so you familiar sometimes with Japan. Now we're here. I'm living in the Fukuoka Prefecture in the Kyushu Islands, and this hospital is my hospital located in the southern part of the Fukuoka Prefecture, and this is my hospital. Our hospital is located beside the big river named Chico River, and this river is very famous for the we know about the kappa is living under the water. So this is a well-known mythological creature, kind of water goblin. And anyways, I am living here. And today I'm talking about the endovascular treatment for the aneurysm treatment. But this treatment is become a very, very common disease. So today I'm focused on the beginning, from the beginning to the present. It's the beginning part of this treatment. And of course, everyone knows the gold standard of the aneurysm was neck clipping. Neck clipping has a long history. It's 1938, Professor Tadandi reported the first case of the clipping. Of course, it's not the macrosurgical surgery. And contribution of this field of the Japanese physician is very, very, very great. Of course, Professor Suzuki Jiro reported JNS in 1979, the thousandth intercranial circular treatment, definitive surgical treatment. And of course, everyone knows that Professor Suita Kencho. And of course, you are in the Fujita, three Professor Kano, Professor Tato, and Kato Yoko. These three guys are definitely giants of this field in Japan. So on the other hand, the first impact of the endovascular treatment for the cerebral aneurysm as Professor Servinenko's detached balloon. He invents detached balloon is founder of the Bart Magic and Bart Medical, and he published the many cases of the cerebral vascular disease using this balloons. majority of the cases the parent artery occlusion, but he did some case of the coil embolization for balloon embolization for the aneurysm itself. And this balloon is used to available in Japan and everywhere in this world. So this is my first case treated with this balloon using a traumatic CCF. So we navigate the balloon-mounted microcatheter, navigate the cavernous portion of the ICA and inflate the balloon. So balloon is automatically sucking out to the cavernous sinus. So after that, we confirm the balloon is outside located outside the ICM in the cavernous sinus. We inflate the balloon using the hemo-MMA. It's a kind of copolymer to fix the balloon. So we did before the touch, we did the DSA and the traumatic is gone. We just pull out the catheter and detach it. It's not difficult. It's difficult. But unfortunately, now we cannot use this balloon. So now when we face traumatic CCF, we have to embolize the whole cavernous sinus from the transvenous approach. This is the last year's case, and finally CCF is gone, but we have to use 47 detachable coils. The cost of the coil means $47,000 US. So it's a very high price. So, and this is about one of the first case of the treated aneurysm treated with this balloon. This is the first case in Kyushu Island. This is done by Professor Goto. He's one of the founder of the Japanese endovasc treatment, and of course he's also one of the founder of the WITN World Federation of Interventional Neurology. And I have a chance to observe his surgery in 1990 in his hospital. We put the one balloon into the aneurysm and detach it, so the aneurysm is gone, and we are very excited about it. And this is another case. It's the only case doing my hospital. Of course, this is done by the Professor Goto. I am just an assistant. This is ICA-C2 large symptomatic aneurysms, and so he navigates the non-detachable balloons into the aneurysms. Neck was relatively small, and so he inflates the balloon and do the DSCAG and confirm the aneurysm is not visualized. After that, he navigates a balloon-mounted microcatheter into the aneurysm. And to compare with the balloon size, the aneurysm is too big, so navigate the second microcatheter at the bottom of the aneurysm. And we inflate the balloon, and we insert several pushable coil to prevent the balloon is moving to the bottom of the aneurysm. He called this technique as the bird nest techniques. And so post-operative DSA is great, and the aneurysm is gone, and we are very happy about it. But unfortunately, the patient suffered from the subarachnoid hemorrhage within the months after treatment. So it's a balloon embolization it works, but it's very difficult, and the indication is very limited. So it's not so popular treatment. So so definitely the breakthrough of this field is Professor Gurgurami's detachable coils. So this coil is highly sensitive for direct current, which allows to separate from the delivery wire. So, but first time his main interest is not the detachable coil, but electrothrombosis. He published these coils in 1995 and Journal of Neurosurgery as special articles. So positive direct current applied to the delivery wire, starting the process of electrothrombosis. But first he's thinking about he insert the coils, and so the electrical current applies. Beside around the coils, there's a thrombus formation, and the thrombus and coils occlude the aneurysm. But in practice, this coil did not have thrombogenicity. But it's very good for us because if this coil has a thrombogenicity, you have faced many intraoperative thromboembolic complications. Anyways, this coil is available in Japan from 1997. Maybe in US 1995, the European country 1991 too. So, but before that, we have from 1995, we can in Japan we can use another kind of detachable core, interlocking detachable cores. It is this approximate end of the coil is connected delivery wire like this. So we push a coil outside the microcatheter. This part is exit from the catheter tip. The coil is automatically detached. And this is the worst case I by myself. This patient underwent the neck clipping 8 years ago for the ruptured aneurysms, and unfortunately he suffered from cervical hemorrhage and admitted to the hospital. And DS showing the found degrowth, maybe degrowth at the neck of the aneurysm as the clip of the besides the clip. So this is 1995. So of course we try to do the neck clipping. We start the neck clipping, but everything is so overheated, so we cannot expose the end itself. So my former boss said I am using this coil for some case of the dural AVF or brain tumor. So he said to me, you should treat this patient, use this coil. And I don't want to do it, but I have to do so because the boss is God. So in the 20th century, boss is God. So all I can say is yes, I can do it. So fortunately, we can insert one coils, and she's dead by late 85 or 6. He never bleed after the second surgery. It's okay. So from that, we started the endovascular treatment for the Adrev. So we started the single technique. Single technique means insert one catheter into the aneurysm, and because after that we use the 2 or 3 catheter into the aneurysm if it's needed. Then we have the remodeling balloon and the neck bridge stent and flow diameter stent. So as you know well, so they become very sophisticated. This is a number of the cases in actual treatment number. So in the 20th century, almost the case was treated with the clipping, the ruptured and ruptured. But the endovascular treatment number is getting higher. And last year, in Japan, even in Japan, more than 50% of patients were treated with endovascular. So this is my personal experience from 1991. First case to last year, I have treated almost 3,000 cases. So we have several adjunct technique, and so balloon demarine, stent, and flow diapater, some things. I will show you some cases. Okay, so this is a double catheter technique. As far as I know, this is the first reported case of the double catheter for the intracranial aneurysms. It's in 1998, the AJNR, maybe I think it's the Canadian group that reported it. This is a wide neck large ruptured vaginal spinage were treated with the double catheter technique. So the post-operative view is okay. So maybe this is a ruptured case, so this patient prevents rebleeding in the acute stage. But nowadays, everybody knows this in this type of aneurysm must have a recurrence. So maybe I don't know, but this patient they have to do the re-embolization again and again. So this is 1998, but in Japan we have more 1996. We have many. Before the 1998, we have many cases using the double catheters. So this is my first case treated with a double catheter. It's a ruptured vaginal chip aneurysm. 2 aneurysms are there, so we navigate one catheter and insert coil and in this part, but coil is not fit to the walls, and if we detach the coil is migrate to the parent barrier chip. So we navigate the second catheter besides the first catheter here, and so insert the small coil. So entangle two coils, the coil the peaks to the wall. So we detach the both catheter and the insert coils again as much as possible to possibly use the ion substrate is used. So multiple catheter techniques are applied for the multilobular aneurysms. We put individual dome, the catheter, and coil. Or before the stent of balloon coming, so such as wide neck aneurysm, one simple technique, the coil, the easily migrate to the parent artery. We navigate to 2 microcatheter and two coils. Insert 2 coils, the alternative little by little entangle 2 coils and create the frame and the coil bit. So after the stent, the balloon is coming. So this kind of patient could be treated with a coil a stent easily. So recently we don't use a double catheter technique so many cases. And the remodeling balloon is used to a very important adjunctive technique. This is the very important the report of the Jacques Morin, published in 1997. In this time, he operated many cases was using remodeling balloons. But we are thinking about if we use the balloons, the catheter is fixed and the coil is we have a more chance of the intraoperative rupture. So in Japan, we hesitate to use it. But this is the first case I use the balloon. This is a ruptured sheath aneurysm treated with another hospital. And the 14 days after treatment, he checked the follow-up BSA and confirmed the coil slip out, or I think incorrectly, I don't know, but the aneurysm is there, so they transfer this patient to our hospital. This is wide neck aneurysm, so we have to use a balloon. So it's the first time we use a balloon. So the post-operative view, the aneurysm is gone, but as you can see, small part of the coil is produced to the ICA. This is a before detachment, the coil is completed inside the aneurysm. Before after detachment, subcut part of the coil is produced into the parent artery. But clinically, it's no problem about it. But it's a so remodeling balloon is used for the stabilization microcatheter during surgery and prevents coil migration into the parent artery. Or sometimes we spare the dome at the branches arising from the dome neck. So we herniate the balloon into the so first generation is called the balloon is kind of stiff. So we have to inflate the balloon very carefully. So this is one case. This is a ruptured vaginal chip aneurysm. We try to treat with one balloon from the left PCA to the vaginal artery. But we inflate the balloon, but this side is not covered with the balloon. So the coil is produced to the right PCA. So we have to use the 2 balloons into the aneurysm. So it's very stressful, but anyway, so you can treat it. But after that, the balloon function is getting better and better. So this is another case of vaginal chip small aneurysm. So on this time we can use super compliant very soft balloons. It's easily herniated to the neck of the aneurysm. So we so nicely remodeling at the neck of the aneurysm. So it's the coil. So finally, this is another case. It's unruptured. The PCOM is originated from the neck of the aneurysm. So this is an unruptured case. So we have to do the tight packing. So we insert 2 microcut into the aneurysm, and another balloon was located at the neck of the aneurysm. So to inflate the balloon and the herniate balloon at the origin of the PCOM, and After that, we spare the original PCOM, and after that, we navigate the two the coils as much as possible from two catheters. This is the demonstrates the beauty of the super combined balloons. This is a PCOM origin. It's a PCOM origin here, and this is a PCOM. So if you use the remodeling, we have to put the microcatheter from IC to PCOM. But if we use super component balloons, it's easily herniated. This is the origin of the PCOM. This is A1. This is A1 origin. So everything so covered with low pressure coil, stent, so valve catheter. So after that, we can navigate insert the coil. That's all. So this the balloon is navigated everywhere. This is MCA, the PCA, PICA, ACOM, everywhere we can use the balloon. So, but I think this is the most tricky case before the stent is available. This is ruptured the vaginal aneurysm. So it's a very neck is 6 meters, the height is 3 meters. It's very difficult. So, but fortunately, this patient has a nice PCOM. So we navigate the microcatheter from ICA to PCOM, and the balloon catheter, and from the vertebral artery, we navigate the 2 microcatheter in the dome. In the dome. So I treated the balloon and the 2 catheter, double catheter. So possible view is has gone without any clinical complications. I think it's a very tricky treatment before the stent is coming. But after the stent is coming, everything is very treatment is become very easy. This is the original first generation stent, Enterprise and Neurohome. This is laser cut stent. Laser cut stent is made from the metallic tube and cut the tube. This is a closed open cell stent. So this is a vaginal chip uncaptured aneurysm, almost same case, almost same form. We put that this it's a closed cell stent, open cell stent. So we need to cover the whole neck. So we deploy the stent. So the neck of the part of the neck, we push the stent a little, and so cover the whole neck. So it's convincingly showing that this is a closed stent. With push the angle is very acute. Stent is king. This is the open cell stent. Did not have a king, but the strap is migrating into the dome. So this is a typical feature of the first generation stent. But it's clinical, it's no problem. We can put coils as much as possible. It's okay. But after that, we can use the second generation stent is available. Open cell stent and braided stent. Now we can use this. Okay. So this is one case, the ICP PCOM origin here. So we put a stent around here. This is a stent at PCOM, only a PCOM. This is we called half-T stent, half-T stent, acid coil. So we put a one stent on here to separate the neck and so after that we navigate the coil. 1 year to follow them, showing the enemy and it's gone. So this is another case. This is a very wide neck vaginal aneurysm. This is of course we can spare both PCA. So this case we have to use two wide stent. 2 stents are there. So we put the 2 stents. Both PCA will be just spared. So that we put coils as much as possible. Several years have passed since I did, but this patient doesn't show any recurrence. This is another case, it's a ACOM rupture aneurysm. In the acute phase, I embolize on the dome to prevent the bleeding. After that, but this patient is very young, so I have to cure this arrhythmia. So this time I have to use the Y stent from first we put the right A2 to right A1, then to transfer the left A2 to right A1 to stent at point. It's okay. It's okay. So finally, we have a stent, a pipeline, the flow diverter stent. It's everyone knows the beauty of these stents, and this is, I know, this is a symptomatic cavernous aneurysms, and it's I put only one flow diverter stent. It's like that, and 1 year followed, the aneurysm is gone. So it's a very good. Put a stent is not difficult, very easy, and good treatment. This is another case. This is a young the C2 unrupture aneurysm. So this case we put a pipeline, but this is the intradural aneurysm. So the pipeline is very effective, but occurs the aneurysm maybe 1 year. So we put some coils and put a stent. So 1 year followed this showing the stent is creates a new vessel. First is the parent artery is deformed, but now the 1 year follows the enterprise stent creates a new vessel. I think this patient we never recover. And finally, you have web. This is the intravascular intra-aneurysmal flow diverter. It just it's very easy. You put the microcatheter into the aneurysm and put the stent. It's this device into the aneurysm. This is immediate post-operative use. The aneurysm is gone, and the follow-up CTA before the discharge 7 days after treatment, the aneurysm is gone. So it's very good, sound easy, and I think it might be have a cure. And so as you know, the web and balloon is available because it's a technological improvement. But as I showed you before, this Professor Severenko, 1994 JNS article, this is complete same as this balloon is almost same as the web. This is a technological improvement. We can easily navigate treating this, and this is surprising. This is he navigated another balloon to avoid the the balloon is produced into the parent arteries. It's definitely balloon neck remodeling. So it's a 1994. He concept was he made the concept. So the Endovasc treatment of several started in the 1970s. The several attempts have been made, but no such result has been obtained. But the development of science and technology has made it possible to treat the majority of cerebral aneurysm. So, but the concept is the concept is completely right. And however, the neck clipping still the alternative surgical procedure. So careful case selection is mandatory for the impressive patient outcome. So thank you for your attention. So I'm sorry, because my English is terrible. I'm close. It's okay. Thank you very much.
Thank you very much, Professor. It was a very interesting presentation. Thank you, Professor Hirohata.
Let me close the PowerPoint. Up, view options, stop PowerPoint. Up. Alberto, you can do that. On the top, view options. On the top, you are viewing somebody's screen. Then on the besides, there is a view options. There is a drop-down box and stop PowerPoint.
Stop. Okay, okay, it stopped. Okay. Okay, so thank you very much, Professor.
I'm sorry, I'm English terrible, sorry.
No, your English is
Sorry about
good.
it.
And we were able to understand your presentation. I would like to start the discussion now. If there are some questions from the audience. I have one question just to start. There is of course, it's impressive how much endovascular treatment has improved in the recent years. There is a technical advancement almost every day. So I have two questions. The first question is, of course, this technical advancement is good for patients, for surgeons, for our clinical practice. But don't you feel that too fast technical improvement can somehow limit this kind of procedure, in the sense that there is not enough time to get experience and mainly follow up with adequate number of patients treated with the same device, because every day there is a new device. Yeah. So there is always the need to try a new device which potentially is better compared to the previous ones. But in this way, it's difficult to follow this wave. This is my first question. The second question is related to flow diverters. There is a debate about flow diverters for ruptured aneurysms. Some people say they can be used, no problem. Some other people are more hesitant because of the double antiplatelet treatment. Which is fine for unruptured aneurysms, but some people are afraid to use in ruptured cases. So I would like to know your opinion and your experience on this.
Yeah. Thank you very much for your very important questions. First question is, I think I'm completely agree with you. But basically, at least in Japan, so every new device is treated in the European country first. Then because Japanese government is very strict regulation to use a new device. So for us, the European country use many cases, and so they as you know, the European country doctors can use many types of the new device, and so using many cases, and some is better, some is good, some is not good. So it's so good one is become the worldwide. So now in Japanese situation, so we are maybe 1 year, 2 years behind the European countries. So we can select that as a European countries that the result. We can see the result of the European countries, and then I check. We decide to use what should I use. But in the European countries, I think it's a very maybe someone is experimental treatment. So. But trying fast, but it's not good. So okay, we stop it. So that kind of thing will occur. So, but in Japan, we don't have we are time to select. So it's my first answer to my first question. The second question is. Flow diverter is so we cannot use the flow diverter for the ruptured, acute ruptured case, but of course, as you know, some countries can use flow diverter for the ruptured case. But now we have many antiplatelets. So we started cryptograph. Now you have the Chicago or new type of the antiplatelet. It's enabled to use very quickly. It's, if you use if you aid the patient drugs, platelet functions used very fast. So maybe I think it's we cannot worry about the flow diverters insert into the for the acute rupture hernias. So maybe the very near future we can use flow diverter for the acute rupture case. But of course, flow diverter is useful for only for the side wall angiomas, not the bifurcation. And the last web I had shown the last case. It's the flow diverter, intravascular flow diverter. It can be used for the rupture case in the many countries, not Japan, but many countries. So technology is getting better, and so maybe near future we don't worry about the rupture, acute rupture or something. Can you understand that?
Thank you. Yeah, thank you, Professor, for your answers. Is there any comment from the audience or any other question, issue?
Yeah.
We also have Tushit, who is an expert of endovascular. So issue, please go ahead.
One is, I will narrate the question, Professor. Thank you for your talk. And there is one question that from Dr. Meshari Aluthoehal. What is your antiplatelets protocol after stunting?
Means neck patient.
Yeah.
We have a next when we use when we use a neck bridge stent, we use dual antiplatelet 3 months.
Okay.
After that, the single platelet 3 months. That's it. But when I use flow diverter stent, metal coverage rate is very high. So we use dual antiplatelet 1 year. After that, we use 1 year.
Thank you.
And so reduce stop it at 1.5 years. 1.5 years.
1.5. Thank you so much, Professor.
And I ask one question to Professor Hirohata?
Yeah.
Okay, thank you very much, Professor Hirohata, for this wonderful presentation. Indeed, it was a great learning experience for everybody. Just I would like to ask you your esteemed comments about the other strategies, like in acute ruptured aneurysms. Some people just come and put in a few coils, and they come back after 2 or 3 days to fill in the rest of the aneurysm to protect the ruptured dome part. What is your comment about this practice?
Yeah, so now maybe I used to do the stage therapy, but now I ruptured and unruptured, we try to embolize as much as possible. Even if we have to neck bridge centuries, I using neck bridge century for the ruptured case. So it's not a hesitate to use the neck bridge century for the ruptured case. Everywhere, all organisms should be treated with the dense packing as much as possible in the first case. We don't want to every patient don't want to surgery twice. Once is better. So
that there is higher incidence of intraoperative rupture as well in acute stages. So what would you advise in a case of intraoperative aneurysmal rupture, coiling rupture?
Yeah, it's always it's a big programs, and of course, if you have the neck bridge balloon neck bridge, you put a balloon at the neck of the aneurysm. We always inflate the balloon that we can stop the bleeding. So, but neck bridge balloon is the big insurance for the when we rupture. But Or you if you face a rupture, we put some cords as much as possible to try to stop bleeding. That's it. I'm sorry, the answer is not good. I know, but
Thank you.
can understand what.
Thank you very much.
Thank you. Any other question or comment? Tushit, you are.
Yeah. Thank you very much, Professor, for this remarkable lecture. I have actually two questions. Am I audible?
Yes, yes, you are.
Yeah, thank you. First question is, what is your experience regarding treating a difficult fusiform aneurysm or some difficult saccular aneurysm with more than one flow diverter? That is flow diverter in flow diverter, or using for the same aneurysm more than one flow diverter. And second question, do you recommend this thing to be practiced?
Okay. First question. Of course, I have many experience of the telescopic stenting for the flow diverter. So the larger trunk, the large aneurysm, fusiform aneurysms. The flow diverter is effective, but to compare with the sacral aneurysms, the complete obliteration rate is lower than the in the fusiform aneurysms. So fusiform large aneurysms, we put the 2 or 3 flow diverter. I think it's maybe at least we have no experience with the rupture after the telescopic flow diverter stent. But complicated occlusion rate is lower than sacral. And I cannot understand the second question. Could you call me the second question again?
Yeah, I will put it another way, that if after deploying first flow diverter, usually aneurysm should be gone by 6 months to 1 year. And
yes, of course. We put one stent, one flow diverter, the shield, complete neck. So of course we followed we followed at least 1 year. 1 year after treatment, the patient showing the annular flow, we put the second stent. So we followed at least 1 year.
Okay, Professor. Thank you. Thank you very much for your explanation.
Thank you very much, Tushi. Thank you, Professor. I think also Professor Yoko Kato is connected now. So I want to welcome Professor. If there is any other question, otherwise we should move on with the next speaker, Dr. Thomas Zilka. Maybe Ishu, you can go ahead introducing our next speaker. Thank you very much, Professor Professor Hiroaki.
Your patient. Thank you.
Thank you. Thank you so much.
Okay, I would like to invite our next speaker, Dr. Thomas Zilka. He is a young neurosurgeon from Slovakia, and he has completed his neurosurgery in 2018 from University Hospital Bratislava, and he has special interest in glioma surgery, pituitary surgery, intraoperative ultrasound, epilepsy surgery, and currently he is working there as a deputy head at Bratislava Hospital, University Hospital, and he has been trained in skull-based surgery, endoscopic sinonasal surgery, and pituitary surgery from different European countries. So I would like to invite Dr. Thomas Zilka to present his paper on implementing pituitary surgery in a newly established department from a young neurosurgeon perspective. Please.
Thank you very much, Professor, for a nice introduction, and good day to you all. And I really appreciate the opportunity to have my presentation, and thank you again for having me. If you allow, I'll now proceed to share my screen. I hope it's working now. And My aim is not to talk about some cutting-edge neurosurgical research today, but I'd rather share with you specific cases maybe that we a little struggled with, and I will be very grateful for any remarks, maybe useful criticism that will allow us to proceed better next time. Just to perspect what I tend to talk about. First, I'll just briefly describe how we do it. I mean, our technique and tactics, and then I will present few specific cases and maybe pose some questions for possible discussion. Our techniques and tactics is as follows. The position is obvious. Patient lying supine with the head slightly tilted to his right side. Our setup is that we actually stand one beside another. So I'm standing on the right side of the patient and the assistant usually slightly next to me. The technique that we use is one man. That means endoscope is held in the non-dominant hand and the instrument in the dominant hand. Usually the approach is done using left nostril. Just very exceptionally, we use binostril approach. We almost never harvest nasal septal flap. As I said, the endoscope is held by hand. And nowadays we almost exclusively use frame navigation using standard Mayfield head holder. We actually abandoned using electromagnetic navigation that we use in the beginning of the program. And regarding the closure, we always harvest fasciolata, always, anytime. Fed just in the selected cases. Every time we seal it, the fasciolata seal inside, just using as an inlay, using glue. If there is a evident arachnoid tear in the arachnoid prolapsing through the diaphragm, we use a targeted taco seal on that. Almost never we use lumbar drain. I have to admit that we have a excellent cooperation with ENT, so they usually perform the approach for us, and maybe in the beginning we can discuss that. I think the right or well-working cooperation between neurosurgery and ENT is crucial for successful pituitary surgery. Now I'll just show short video depicting our tactics. It's a video of this functioning pituitary adenoma. That's a female with acromegaly, and I'm just going to go very quickly during the video. I know that the video is a little shaky. That's because the endoscope is free held in the non-dominant hand. You can see one instrument, dural opening, usually U-shaped. Some centers use X-shaped, use a U-shaped dural opening. This was one of the earlier videos when we used a electromagnetic navigation using the navigated sucker. This is the exception when the assistant is helping using sucker and the surgeon is working with the curette. I'm just going to skip it to the inspection of the cell region. We see no residuum of the tumor, and this is our closure. This is a quite standard procedure how we do it. This patient did well. She had a good laboratory cure of her acromegaly. We proceed next. I think the indication criteria they are worldwide known, and only thing that I have to maybe repeat, it's obvious in non-functioning pituitary adenomas we are guided by its size and there's expansion behavior, whereas in the functioning pituitary adenomas, we focus on hormonal overproduction and try to manage it. Just maybe tiny remark from a young surgeon, and I have limited experience, and in the beginning of this kind of surgery, my imagination was that it is harder to deal with larger tumors than with the smaller one. I then learned that the opposite is true. It's true because in large tumors, especially non-functioning ones, a gross total resection is always satisfactory, almost always. On the other hand, in functioning tumors, small millimeter size microadenomas can lead to severe clinical difficulties to the patient, and to manage these cases surgically is proven to be quite challenging. This is the first case I want to share with you, and to pose background, some baseline for further discussion. It's 61 years old male with severe visual symptoms. He had a bitemporal hymenopsia, and he was examined with this MRIs. Please note just the left side of the tumor, or maybe even the right side, where there are signs of cavernous sinus invasion of the tumor. It was a non-functioning tumor, so we managed to achieve nice gross total resection, and this is a follow-up MRI that confirms the resection. But obviously there is some residue of the tumor in the left cavernous sinus, and maybe some small, barely visible residue contralaterally. We observed the patient, and this is next follow-up MRI, where the residue on the left side in the cavernous sinus has grown. So maybe this is the first pitfall, first question that we stood before: how to manage this growing residuum. Since it was intercavernous residuum, we opted for radiosurgery for the left side. That was, I think, successfully done. But what happened next is that the right-sided residuum started to grow, and it was quite close to the optic nerve, and therefore radiosurgeons, they didn't want to do the radiosurgery up front, and asked us for the option of reoperation. We actually planned this patient for reoperation. Haven't done it yet, but I wonder maybe what would your approach be if you would refer the patient directly to the gamma knife, or maybe try to do it surgically. I wonder if there is someone who would opt for the surgical attack, even on the left side that we have previously radiated. I believe that maybe discussion would be better after I finish. This is different case I'd like to share. When I first looked on that, I thought, or we thought, that would be an pituitary adenoma, and there were no endocrinological disturbances. I was a female, 65 years old. She had quite severe progressive visual loss, and what is remarkable on the imaging is the close relationship of the tumor to major vessels, mainly to posterior vasculature, to basilar artery, V1 and SCA on right side mainly. Well, spoiler alert, it was a meningioma. This is a resection video. I'm just going to skip through it really quickly. We didn't know it was a meningioma during resection, so we little adapted our technique using two instruments and a free held endoscope, and we managed to achieve this kind of section. You were able to appreciate basilar artery and STA and P1 on the left side, but we were struggling a little with the right-sided or the superior right portion of the tumor that was stuck to the base of the third ventricle, and also we were expecting the large vessels stuck to it, mainly in this angle. The approach was widened in this case in order to reach there, but in the end of resection, we weren't still able to remove the tumor radically. So we left the residue there. I think I can post a video now, and this is the residue that we left. Actually, in the angle of P1 and SCA, and the residue is not growing. But I can't stop to wonder if we should have tried better, maybe widen the approach to remove the tumor or more radically, or if this is a satisfactory result. Her vision dramatically improved, and so far we haven't referred the residue to the radiosurgery even, because it's not growing. So this is maybe something I'd like to discuss later and to learn to do better. And the last case I want to share is something that we fight quite often. It's a functioning microadenoma, young female, decompensated Cushing's disease. She was operated first time in 2018. Was a time our department didn't exist. And she was operated microscopically. That means using via sublabel incision and speculum and microscope, with no success. This is the imaging that we did before the operation we performed in 2021. This is the post-op scans that we achieve. Obviously, there is some resection cavity, but she had just a slight improvement, or better put it, unsatisfactory improvement of her laboratory status. Therefore, we opted for early reoperation. This is a early MRI scan, but we weren't able to cure her laboratorily. So the patient was started on ketoconazole, and she was referred to Gamma Knife. And my question is, how valid do you deem our indication for reoperation and reoperation? And what would the management of this patient maybe be if someone would opt for cavernous sinus opening, or just no one, or just not imagine about, not to think about that, just how to further manage the patient. Thank you very much again. I think that I just finished in time, and I will be very grateful for any hints or remarks. Thank you again.
Thank you. Thank you, Thomas.
Thank you very much. Nice presentation.
And it's good that you put up questions, because that's how you can learn more.
Can you stop the share screen, please?
So the platform is open for discussion. Please give your valuable comments. And
so actually, I have a couple of questions. Thank you, Thomas. Nice presentation. As I said, I enjoyed. If I got it straight, you do this kind of operations with ENT colleagues.
Yes, all the time we do.
All the time. Okay. Yeah, my question is there any reason why you routinely use fascia lata and you almost never use the nasoseptal flap?
Well, actually, that's a great question, by the way. The reason is that we kind of adopted our strategy from a different center in Czech Republic, and then they have been successfully doing so for several years. So that's why we adopted it. But in my opinion, I see the gathering of the small fascia lata less invasive than gathering large nasoseptal flap. That's one view, and another view is that we are trying to save the nasoseptal flap for reoperation, CSF leak, and etc. So I just don't want to shoot all the ammunition at first hand. That's why we do not use it routinely for adenomas.
I understand the strategy. Yeah, it was interesting for me to know, because we do the opposite right now. We use very often the nasoseptal flap. We prepare at the beginning of the operation this Haddad flap, and we use fascia lata only if we have serious problems or in reoperation. So it's interesting to see different strategies in different centers. And I was curious because as you operate with ENT colleagues, I would have expected that ENTs prepared the nasoseptal flap.
Actually, they would love to do it, but they hate to follow the patient after that. We have a strategy of follow-up that they are following the nasal cavity, and we are following the intracranial part of the case. So if they learn that they would actually they would have to take care about the patient's nose after having done nasoseptal flap, they opted not to do it. I don't know how your follow-up routine is designed.
Yeah. We usually for standard operations we do the approach by ourselves. So I do the nasoseptal flap and I do the approach. I complete the operation. For extended, approaches, we ask collaboration from ENT doctors. But in any case, patients are followed up also by ENTs. So ENTs check with the endoscope during the follow-up if the healing process is proceeding correctly. So there is a good collaboration about this. Thank you very much for your explanation. Very interesting.
So I have a few comments, Dr. Thomas. The thing you were asking about the further plan of 2 cases. If I remember correctly, that what should be the further plan for Cushing disease patient. There was small tumor, and one attempt was not up to the mark, and because of the excessive secretion of steroid hormone, she is still suffering. Still, she is having small tumor. One is use the 30-degree endoscope and try to go inside the cellar and look for the tumor residue on the wall. And the different shapes of the ring curettes, they can help you to scrape the tumor tissues on the lateral wall, which are missed in previous surgeries also. I think you need to change your strategy to remove those tumor residues which were left on the side wall. I saw that you were able to remove the central part and the upper part, but residue was always left on the side wall. In first large case, the residue was present on the left side, and in the Cushing disease, it was on the right side. Am I correct? Are you getting my point?
Yes, I'm getting an excellent point. Thank you very much. Well, actually, usually we operate only using 30-degree endoscope. Just the ENT colleagues, they sometimes opt for 0-degree for the approach. And the checkup of the cavernous sinus wall that you described, of course we do it, and we did it even in this case. It was badly shown in the video. I apologize for that. We didn't find in the last lady I presented, we actually didn't find a seeable residue on the right side of the residuum, and we even checked the left side if there isn't something below MRI resolution, and we didn't find it. Since she was 31 years old in the fertile age, we obviously we didn't opt for hypophysectomy, but always we tried to sweep all the cell region inside within the cell using the endoscope. Well, I have to admit, I don't have no experience using 70-degree endoscope. Maybe that might be of help, I don't know. But the question that was there was if we dare to open the cavernous sinus, which we didn't.
Okay,
I think the residuum is there in the cavernous sinus, the small one, in the last case. That's my opinion. I don't know what do you think, but I think that the residuum is there.
The thing is that if the tumor has already invaded into cavernous sinus, then the bleed is less because the tumor is already occupying the sinus area. So the scraping will help. And as such, you know that the pituitary tumor, they are vascular. They bleed and the bleed stops after removal of the tumor. So if you are going inside sinus and there is sinus invasion, still there is no need to fear. I think the different shape of the instruments, like I don't get the idea of how different type of shapes of the instruments you are using, and the different shapes of ring curette, they can help you in taking out the wall, the right and left wall. Because I myself have changed this strategy after I got residue on the lateral side. Whenever I saw the scan, and in large cases when I find out that the residue was on the lateral side, so I started using different shapes of ring curette more and more to scrape the tumor, and I used it continuously, so that if the small residue is there, I still do it, and finally I got what I wanted, like good scans, complete resolution of the tumors. And this happened with me. I got one acromegaly case, and he was very severe acromegaly. I attempted first open surgery because at that time I was not doing endoscope. So the tumor residue was left near the right internal carotid artery. Then I planned this endoscopic surgery, and while removing the tumor, the internal carotid artery got tear, and it was massive. And somehow I managed patient, and patient survived, but I couldn't remove tumor. So the third attempt was again after 6 months. Then I planned I will go for open surgery, but it was very difficult because endoscopic I was fearful. So what I did, that I collected different shapes of ring curette, and my focus was only on the entry into the capsule, because now the capsule was also hard because of previous 2 surgeries. So I just entered into the tumor after finding the capsule, and I started using different curettes repeatedly. I did curette, and I was not satisfied until it I was there was complete stoppage of blood. Then I thought that I have completely removed the tumor. When the bleed was stopped without surgicel or gel form, then I thought that now the tumor has been removed completely, and this helped. Post-op scan was clear. So this is my personal experience, that if you do repeated curette with different shapes of curette, finally you will be able to remove the tumor in pituitary
My
surgery.
limited experience, we a little struggle a little bit to achieve remission in Cushing's diseases, whereas in all acromegaly cases we achieved radical resection and remission. And I would like to ask, if I may, if you sometimes open the cavernous sinus sharply, if you know that the residuum is there. That's maybe a question related to the first case presented I have.
No, I do not open sharply. I do not open sharply because that I also fear because of the
I am aware of the risk, of
yes,
course.
yes, because I believe that after getting experience of at least 100 pituitary tumors, then I will be able to open the cavernous sinus sharply. It's up to 30-40 patients, so still I'm
Because
learning.
many times we find ourselves in a place that we have used different shapes of the curates, for example, shaped like a tennis racket or something behind the wall, and then we check the wall of the cavernous sinus. It seems clear, but we have this tiny feeling that there is something behind the wall. But I have a great fear. I do not dare to open the cavernous sinus. I don't have the technique. I don't have the knowledge. That's what I was wondering when I made the presentation. If someone could give me advice how to start with opening the cavernous sinus endoscopically.
Okay, I think somebody else might help. Do we have any other comments?
I just have a comment, and I can say I can ask a question. Please, first I want to send my regards to Dr. Thomas, who is my friend. I have met him in Bratislava when I was a fellow of famous Professor Juraj Steno, and he was his, I can say, best resident in that time. And we were sharing experiences, etc. So we are stayed friends for a long time. Anyway, regarding the question, what Thomas asked, how to go further with the residual tumor, I believe that in our people we say don't cut the tree where which you are sitting on. So if we leave all the residual tumors for the gamma knife, and if we send, I can say, aneurysms for the endovascular treatment, on the end, all of us microsurgical trained surgeons will do just the spine. I believe so. So I think we should go as much as we can for the extended approaches and try to perform gross total resection. Anyway, on the beginning of the career, as Dr. Thomas is now, as a young neurosurgeon, if you are afraid to go for a cavernous sinus, then it's fine to leave it for gamma knife. But with the experience, it will come as you will do as much as you can. Maybe I believe that the Professor Alberto has the most experience of us here in pituitary surgery and in endoscope. So I'm asking about the strategy for how do you deal with the enormous bleeding from the cavernous sinus? How do you deal with that? Anyone can answer, of course. What is your strategy for the huge bleeding? Thank you.
Well, yeah, thank you, Adi. Well, first of all, I have the same opinion of issue about sharply opening the cavernous sinus. I also don't sharply open the cavernous sinus usually. If I have a huge bleeding, of course, I use compression with cotonoids, and just wait. This most often is enough to stop that kind of bleeding. It's a venous bleeding, so just be patient, don't panic, put something inside and wait. But I agree with Issue saying that probably sharply opening cavernous sinus, it's something that can come after a huge experience when you feel more comfortable doing this kind of maneuvers. So this is my opinion.
I can tell you what to do when you accidentally tear carotid artery. That I can tell with my experience.
You have direct experience.
Yeah, I have direct experience, and it was panic mode. But still, what I did is I immediately compressed the same side carotid artery. I was not fearful for the stroke and that I have to save the life. So I immediately pressed the carotid artery on the neck. And what is the patient was acromegalic. Bilateral middle turbinectomy was already done. So I used my other finger to directly put and try to press the gauze, and those pieces were already put inside the cotonoid patties, and I started pressing it with my finger. It was inside nose and I was pressing it, and from the other nose we were putting warm saline repeatedly, and the one hand was here pushing the carotid artery, and then somehow we were able to manage without dropping the blood pressure. And then I discussed the same case with Tushit, And he told me that what you can use is you can use Foley's catheter, and you can try to pass it and inflate the bulb. If you are able to see the site of bleeding, try to put the Foley's catheter near that and inflate 30 ml bulb. It will also press the bleed site. That's how you can you might be able to save the patient or
Right.
save the life.
I have the memory of one patient we managed exactly in this way, with a balloon inflated inside the nose. This could stop the bleeding, and we had time to go to, angiography suite and fix the problem. Yeah.
So as you mentioned, you inflate the balloon in the nose or just in the nose?
Yes. If you are in a very big, of course, you have to try everything, like Ishu said, compress a carotid artery on the neck and put cottonoids and compress, of course, as much as possible, more than with a venous bleeding. But if you are not able to stop the bleeding, this extreme maneuver can be helpful, inflating the balloon inside the nose. That is strong enough to compress carotid artery and stop the bleeding.
And artery, they are good that they have a tendency of vasoconstriction, and usually we give sharp cut while using some kind of, so there is not a complete segment is taken, it's only a sharp cut. So with time there is vasoconstriction and spasm, and the risk is there is stroke may occur, but you will be able to save the life.
Yeah, the main problem with this technique is not how to inflate the balloon, is when and how to deflate the balloon. That is the biggest problem.
Yeah, because you keep your finger crossed and
right. Maybe after some days you have to be brave enough and decide to deflate the balloon.
Yes.
We say it when we have a problem in the operating theater, call the neurosurgeon. Okay.
Okay, thank you very much. Is there any other question from the audience? I see Professor Kato is connected. Professor, are you online?
Thank you very much for a nice presentation, but I missed most of the part. But the both says Hirohata talked about endovascular, and also another guy from Bratislava gave us a so nice presentation. But both is very minimally invasive. I think the endovascular and also the endoscopic procedure is the future neurosurgical. I think the field. I think both are very nice presentation. Thank you very much, and thank you for organizing such a wonderful alumni meeting every time.
Thank you, Professor. Thank you for always helping us.
Thank you.
And a big hug from all of us. So thank you very much to our speakers. Thank you, Ishu, for co-moderating with me. Thank you, Raja and Liu, for helping with the organization. Of course, a big thanks to Professor Yoko Kato to join us also today. And thank you to all the friends who joined, Adis, Neha, Shandong, and I saw also Iti. Is he still connected? Maybe not. I, of course, thank Temur and Kabibullo. I see many friends today. So thank you so much. And we will meet again in 1 month with a new Fujita alumni meeting webinar. Thank you so much.